So I want to take you back to 2008. At that time, I was living in the United Kingdom, in England. I'd lived there for about 10 years. And on February 26th of 2008, a study that my colleagues and I had done on antidepressant medication was published. It's a kind of study called a meta-analysis. It's a fancy term for a very simple thing, basic conceptually. It's just you take the data from a whole bunch of studies that have been done on a particular topic, and you put them together. One study will tell you something, 3 studies tell you more. The more studies you have, the more it tells you, but you have to have some way of putting it together. And you do that with what's called a meta-analysis. So that came out on 26th of February, 2008. And I woke up that morning to find that it had become front page news in all of the major UK daily newspapers. 2 years later, it was still making news with a 5-page cover story in Newsweek. And 2 years after that, on 60 Minutes, the following was aired.
The medical community is at war, battling over the scientific research and writings of a psychologist named Irving Kirsch. The fight is about antidepressants and Kirsch's questioning of whether they work.
Somehow, I had been transformed from a mild-mannered university professor to a media-hyped superhero or supervillain, depending on whom it was you asked. What had my colleagues and I done to deserve that notoriety? Well, to tell you that story, we have to go back even further to 1998, when we published our first meta-analysis on antidepressants. And what I have to tell you about that was in 1998, when we did our first meta-analysis, I had no real interest in antidepressants or in evaluating antidepressants at all. I was interested in the placebo effect. I've always been interested in the placebo effect. How is it that a pill with no active ingredient, or an injection or whatever, with no active ingredient can produce the kind of changes that you sometimes see with placebo? You might say I was addicted to placebo research, and I tried to kick the habit. I went to Placebos Anonymous, where the first step was to admit that I really didn't have a problem at all. But it didn't work. I just couldn't stop researching the placebo effect. It was just too fascinating. You know, it's just a strange and wonderful phenomenon. Here's a few things you might want to know about the placebo effect that perhaps you already know, but perhaps you don't, because there are all kinds of things that shape the placebo effect. For example, the placebo effect can depend on the color of the pill. Here's what we know, that blue pills have a much better sedative effect than either red or orange pills. And red pills have a much better stimulant effect than blue pills. And if you want pain relief, you're best off also having a red pill. It does better than a white, blue, or green pill. Same lack of ingredients, just the color of the pill. The dose makes a difference. 2 placebo pills are more effective than 1 placebo pill. And 4 placebo pills are more effective than 2. When we do placebo studies with pills, we usually say that you need to take 2 pills twice a day. Very effective dose. The strength of the medication that you think you are getting makes a difference. So placebo morphine, that is a placebo pill that's labeled morphine, is more effective than placebo aspirin, much more effective. And if it has a brand name, it's more effective than if it's a generic. Of course it is. The drug companies know that, and they count on that. Why else would you spend more money for a brand name when you can get what's chemically the exact same thing in a generic? The price makes a difference. A more expensive placebo is more effective than a cheaper placebo. You tell the person, this placebo, this costs, the prescription outside of this study, it costs $10 a pill, or it costs $1 a pill. You get a stronger placebo effect when it's more expensive. The mode of administration. What do I mean by that? A placebo capsule is more effective than a placebo pill. A placebo injection is more effective than a placebo capsule. And surgery, that's the most effective placebo at all. And you might say, oh, he's kidding with that. But there have been trials of surgical procedures that have involved sham surgery, placebo surgery. The first going all the way back to the 1950s when they used to do a procedure called mammary ligation. And what they would do would be to cut open the patient and tie off the mammary artery, and that's going to change the blood flow to the heart, and that's going to help relieve angina. And in fact, it had about an 80% success rate. And everybody assumed it was a good surgical procedure, but there were 2 research labs around the same period of time, I believe it was the late 1950s, in 2 different locations that had some doubts. And they wondered whether this might be a massive placebo effect. And so what they did is they designed clinical trials. They both got published in the same year, but with different sets of subjects, different data, where they looked at one group being given the real mammary ligation surgery, the other group being given the sham surgery. What was the outcome? The real surgery produced 73% improvement. The sham surgery produced 83% improvement. I can't say with this one that the sham surgery was better than the real surgery because that difference was not statistically significant. They were basically both the same, and they don't do mammary ligation anymore. And you might wonder, is it ethical to have placebo surgery in a clinical trial? It's a very difficult question. Take people, you cut them open, and you sew them back up again. Now, what you should know is that's done with informed consent, so the people know that they might be getting the sham surgery, or they might be getting the real surgery. One of the things you have to think about is what the ethical consequences would have been had they not done these studies. We would still be doing placebo surgery on hundreds of thousands of people with no one, not the patients and not the doctors, and no one knowing that it was a sham procedure and that the procedure itself was not having any effect. Much, much later, this was about, I'd say about 15 years ago, a study was done on a procedure called arthroscopic surgery for osteoarthritis of the knee. Again, a procedure that was deemed to be very effective. And again, there were some physicians and researchers in Texas who had some doubts about it. And so they designed a clinical trial in which one group of patients got the real surgery, and another group, they opened up the knee, they closed it back up again. They made all the noises as if they were doing the surgery. The patients didn't know which was which. 2 weeks after the surgery was done, people who had gotten the placebo surgery were doing significantly better. Now I can say it's better than those getting the real surgery. It was on things like being able to walk up and down stairs. They thought, well, maybe it's because these people had been spared the surgical trauma, maybe. 1 year later, the placebo surgery still outperformed the real surgery by a small degree, statistically significant. It was a large study. 2 years later, a 2-year follow-up, no significant differences between the two groups. There is no advantage to the surgical procedure of arthroscopic surgery beyond the placebo effect. Now, people get better. And as you can see from the 2-year follow-up, that lasts, the improvement lasts. But it's not the surgical procedure. It's the powerful placebo made more powerful because it's surgery. This is a real thing. And then there's the condition being treated. Placebos are not panaceas. They don't work for everything. If you compare placebos to antibiotics for bacterial infections, none of the benefit is a placebo effect. Placebos do not have any impact at all on bacterial infections. They have a pretty good effect on pain. About half of the effect of a pain reliever, whether it be morphine or aspirin, is due to the placebo effect. You can get it with the placebo, you get about half. So remember, morphine is more effective than aspirin. Placebo morphine is more effective than placebo aspirin. Depression. As it turns out, as we now know, about 80% of the effects of antidepressant medication are duplicated when you give people a placebo in the clinical trials. And I'm going to argue that even that 20% difference may also be a placebo effect, but we'll get to that. Well, as I said, back when I started this research, I wasn't interested in the antidepressant effect. I was interested in the placebo effect, and it occurred to me that depression was a place where you ought to find a reliable and robust and relatively large placebo effect. Why? One of the core features of depression is a sense of hopelessness. If you're depressed, almost by definition, you're hopeless. You're feeling hopeless. And what are depressed people feeling hopeless about? Some of them, many depressed people, are feeling hopeless about many things in their lives, but including their own depression. They don't feel they will ever get better. And that's depressing, because depression is really awful. And so it stands to reason that if you give someone a treatment that gives the promise that this will help you get better, that's going to counteract the hopelessness. That can lead to a sense of hopefulness and thereby help diminish the symptoms of depression. So we said, well, that's a good place to look at the placebo effect. We weren't interested in the drug effect. We knew the drug worked. We thought the drug worked. I knew at that time that antidepressants were effective. I had no reason to doubt it. In addition to being a professor of psychology at the University of Connecticut at that time, I also had a clinical practice. I saw depressed patients, clients. If they were very, very depressed, I sometimes referred them to psychiatric colleagues. I'm a psychologist. I could not prescribe medications, but I had colleagues who could, and I would say, it might help. Oh, I'm so sorry I ever did that. I have to apologize to all of them. I said, but I didn't know any better. I said, it might help to get you started, to help start your progress with an antidepressant, which has been shown to reduce depression, and then we can work on some of the issues that have led you to be depressed. Seemed like a reasonable thing to do, and sometimes it didn't work, didn't seem to help at all. Other times they'd come back and they were doing better, and I assumed that when they were doing better, that this was due to the antidepressant drug. So I wasn't that interested in evaluating it, but here I can look at it. We looked for clinical trials in which depressed people had either been randomized to get a placebo or been put on a waiting list, no treatment at all. They'll get treatment later for the benefit of this particular trial. We want to compare what happens when nothing is done. You're put on a waiting list, which is not nothing. But now, where are we going to find clinical trials in which depressed patients have been assigned to get a placebo? Only one place, the drug trials. So we had those data. We had the drug data, and so we analyzed them as well. When you are a researcher, you have data, you analyze it. See what it's telling you. And what I'm showing you on this slide now is the difference in depression between before they got the treatment and afterwards. In a group of clinical trials. There's a meta-analysis now based on the published literature. And on the right-hand side, it's the unit we use, standardized mean difference, you don't have to worry about. I can just tell you that this is a good size effect in terms of pre to post improvement. People got better. Not everybody, some did, some didn't. Some got better very much, some not at all, some just a little bit. But on average, there was a fair amount of improvement for the people who were given the drug. There was also a lot of improvement for people who were put on placebo. And very little improvement among people who were put in a wait list. They didn't have this sense of hope, this reassurance that they're going to get better. One way of looking at that is that 25% of the response to the drug would have occurred no matter what you did. That occurred without even getting a placebo. That was just natural history, spontaneous recovery. In a relatively short time, these are mostly trials 4 to 8 weeks long. Most antidepressant efficacy trials are about that length. Another 50% of the response to the drug was due to getting that placebo pill. That was a real placebo effect. We're looking at here is the difference between getting a placebo and doing nothing, being put on a wait list. So that's a real placebo effect. But here was what, at that time, was a surprise and a shock to me. That meant that only 25% of the response to the drug was a true drug effect. Only 25% could be linked to the chemicals in the drug. The rest you got in people who were given the placebo that had no active ingredient at all. And that seemed very small for a treatment that had been widely heralded as constituting a revolution in our management of depression. Before we published it, we said, we must have done something wrong. Maybe some antidepressants are very effective and others are very ineffective, and by lumping all antidepressants together, maybe we've underestimated the effectiveness of the effective ones, of the good ones, and have overestimated the placebo effect. So we went back to the same studies we had just analyzed, and we looked at what drug, what kind of antidepressant had been used. Some were tricyclics, that's the older generation of antidepressants. Some were SSRIs, the most popular antidepressants today. There were other antidepressants in some of these trials. Same pattern. And then we found some of them involved drugs, active drugs, that were not antidepressants at all. Included in our set of studies were studies on the effects of lithium, which is used for bipolar disorder, not on bipolar patients, but on patients with unipolar depression. Bipolar is manic depression, where you cycle between mania and depressive states. Others were studies of tranquilizers, barbiturates, benzodiazepines. One was a study of a synthetic thyroid hormone given to depressed people who did not have a thyroid disorder. And what was the result of that? Same as the others. If you want to see how reliable it is, I'm going to express this placebo response, that's the darker red bar, as a percent of the drug response. And you'll see it's identical. 3/4 of the response to the drug was duplicated in the placebo condition, no matter what the drug was, even if it was a drug that's not an antidepressant. So the question is, what do all of these active drugs have in common that the placebos don't have? Any guess? Side effects, absolutely. Before we even talk about why it's important, just an example of what that means. If you look at the therapeutic benefits of this tricyclic antidepressant, imipramine, it's just like, this is one particular study, and you can see that it's just like the data we found in our meta-analysis, just a little bit better than placebo. If you look at the side effects, it's a lot worse. Placebo is producing very few side effects. The imipramine, a lot more. Now, why is that important? Well, the placebo has an evil twin, the placebo effect, and it's called the nocebo effect. And just as thinking you are going to get better can lead you to get better, thinking you're going to get worse can lead you to get worse. So a placebo can produce some side effects if you think you're getting the real drug and it's going to give you these side effects. But with antidepressants at least, the nocebo effect, the side effects, are much, much, much smaller than the therapeutic effects. But why is that important? Why am I talking about that part of it? And what I have to ask you to do is imagine. Imagine that you are depressed, and I'm imagining it too, and we've been recruited to be subjects in a clinical trial for an antidepressant. Now, before the trial can begin, before they can begin treating us, we have to give informed consent. They have to inform us, and we have to consent to be part of the study, sign it on a dotted line. And in that informed consent procedure, they tell us, this is a double-blind trial. You may get the active drug, you may get the placebo. And because it's double-blind, that's not what double-blind means. No. What double-blind means is that we're not going to tell you. You won't know whether you're getting the active drug or the placebo, and the doctor won't know whether you're getting the active drug or the placebo. So in that sense, you're both being blinded to which group you're in. And you're told, now, the therapeutic effects may take some weeks before you notice them. And you're told the active drug also has side effects. They don't take some weeks to be noticed. And you're told what the side effects are. You may experience dry mouth, nausea, sexual dysfunction, and there's a whole long list of side effects that you might experience from the active drug. And then you say, okay, I'm willing to do that, and you sign on the dotted line, and you see the psychiatrist, and you are given a pill. Now, I would wonder, which group am I in? I don't know. They didn't tell me. It's double-blind. My mouth's getting dry. That's one of the side effects that they told me about that the active drug produces. That means that I'm in the active drug group. Hooray! I feel better already. You see, until I figure that out, say, okay, maybe I'm getting an active drug, maybe I'm getting a placebo. Once I figure it out, I know I'm getting the active drug. Isn't it likely that the placebo is going to have a larger effect once I think that I know which group I'm in? Here's what we know about these clinical trials of antidepressants. Both the doctors and the patients break blind, and that means can figure out under certain conditions which group they're in. What do I mean by certain conditions? If you ask, it's rarely done. It should be done in every single clinical trial. It should be required to be done in every single clinical trial. It's very rarely done, but in some trials, they have asked patients, what do you think you were given, the drug or the placebo? And they asked the doctor, what do you think this patient was given, the drug or the placebo? And here's one of the few clinical trials where they did that. And what you ought to get, if it's just if they really don't know, if they don't have no ideas, you ought to get about a 50% accuracy rate, right? And for patients in the placebo group, that's just what you get, about a 50% accuracy rate. So 68% of them actually in this study said, 59% said, oh, if you make me guess, I'll say I'm in the placebo group, and 49%, well, I think I'm in the drug group. They really didn't know. But for the patients in the drug condition who'd been given the real drug, 9 out of 10 of them said, oh, I've been given the real drug. How did they know? I think they knew because they got side effects. The doctors can even tell which patients are in the placebo as well as which patients are in the active drug group. Amazingly accurate. It's supposed to be double blind, it's really double talk. Patients in the drug group know they're getting the active drug, which is likely to boost their confidence, increase their hopefulness, get a bigger decrease in their hopelessness, and thereby give them a therapeutic benefit. And I don't have to just speculate about that because we have some data on that. And these are clinical trials. These are all the clinical trials. Out of the thousands that have been done, these are the only ones in which they ask people, what are you on? And what you see plotted on the left-hand side are the patient's responses, and on the right-hand side are the doctor's responses. The raters, the people who are rating how depressed they are before and after the trial. And what you see on the vertical axis is the effect, the amount of difference between drug and placebo, with that horizontal line being no difference at all. And what you'll see is the more people think they're on the drug condition, the more accurate they are in guessing, the more they break blind, the bigger the difference between drug and placebo. So what are these drug-placebo differences that we looked at in our clinical trials, where you get this relatively small but difference between drug and placebo, but you do get a statistically significant difference? You might think of antidepressants as extra strength placebos as opposed to ordinary placebos in these trials. You're getting a placebo effect that's magnified by the knowledge that you're getting a real drug compared to thinking you might be getting a placebo.